Hi, everybody. Welcome to the Virginia Tech Wilderness Medicine Fellowships Journal Club series. This month is covering global health, specifically more of like a global emergency medicine. I will be joined by two of my actual co-graduates and current third-year residents, second-year residents, almost third-year residents at my alum residency program, Henry Ford Macomb. So Dr. Kyle Martin and Dr. Elizabeth Barrett. I'm going to, for the most part, kind of hang out in the background and let them take it away. But one thing first, this is the end of our 6-month cycle. Within the next month or so, I'll compile the participation logs and then submit the FOM certificates. So just keep an eye out for your emails from me within about a month or so. But otherwise, Lizzie and Kyle, please take it away.
Let me see. I think I'm having a rough time figuring out how to share my PowerPoint presentation. For some reason, it's not populating. And you have it as a backup, right, Justin?
Yeah, I've got it as a backup, and I make sure it should be.
Let me see. There we go. I got it now. All right. Can everyone see that okay? Cool. All right. Well, I'm Kyle Martin. I am the Associate Fellowship Director for the Global Emergency Medicine Fellowship at Brown University. I'm originally from Michigan. I grew up outside of Detroit, and I did my residency in the same place that Justin and Lizzie did at Henry Ford in Detroit. And then I came to Brown afterwards for my Global Emergency Medicine Fellowship. And after that, I've just continued to work at Brown. I went to Kent Hospital, Kent County Hospital in Rhode Island after I finished with my fellowship for 2.5 years. Then I came back to Brown after that, and I've been working at Brown ever since. I originally started working in Haiti, and now I work mostly in Rwanda for a variety of reasons. But this presentation is really focused on the work that I did in Haiti after the earthquake and some of the current efforts that I have in Rwanda. And then Lizzie's going to expand on that. And then we're going to talk a little bit about this new movement in global emergency medicine, which is decolonizing global emergency medicine. So this idea of like, how can we as global emergency medicine advocates and practitioners try to create more equitable partnerships across borders? And there are a variety of bad examples and a minimal number of good examples. But today we have a Journal Club article where we can focus on some of the ways that potentially we can work with our partners across the seas to create equitable partnerships and try to remove some of the structural violence that's been present from the past and that has been imposed largely through colonial processes, but also through some of the historical transatlantic slave trade as well. But for now, we're going to focus on global health. We'll talk a little bit about Haiti and Rwanda. And I love Haiti. I've been traveling to Haiti since I was a kid. So I traveled to Haiti for the first time when I was 12 years old. I grew up in a family that was pretty conservative Christian family. So I went there with my dad and a group of other people when I was 12 years old. And we went on a literal church building sort of trip. And then after that, got connected with a nonprofit organization that worked on rainwater harvesting, and then continued traveling with that organization all through high school, college, and then, a little bit through medical school as well. So Haiti's been somewhere that's near and dear to my heart. Through all the time that I've been traveling there, I've learned Haitian Creole, and I have several friends throughout the country that I stay in touch with. And that's why this is such an important sort of story for me to tell about the earthquake. I think, some of you might have been pretty young when the earthquake happened. I feel like I'm getting older and older every year, which is actually very true. But for me, I was actually in my second year of medical school when the earthquake happened in Haiti, and that happened on January 12th of 2010. It was a magnitude 7.0 earthquake, and one of the important factors is that it took place at 4:53 in the evening. And the reason why that's important is because most people were at home around that time. So families were either getting ready for dinner or were already gathered around the dinner table, or people were coming home from work at that point in time. So a lot of people were indoors when the earthquake happened. And in Haiti, unfortunately, there was minimal enforcement of the building code. So a lot of the buildings that existed, particularly in Port-au-Prince, were built with poor quality. Construction workers and contractors will do whatever they can to cut costs. And when you're putting together buildings in places where building codes might be laxly enforced, you might use a little bit less cement, for example. And that in Haiti led to more watery concrete. And that watery concrete just does not meet the standards that are necessary for when earthquakes occur. So when a 7.0 earthquake took place in Haiti, it meant that pretty much every building throughout the city of Port-au-Prince collapsed. And this led to just catastrophe. In fact, the Haitian people still refer to the earthquake in 2010 as the catastrophe. They won't refer to it as the earthquake, they refer to it as the catastrophe because of how just dramatically and absolutely terrible it was. So approximately 100,000, 300,000 people were killed. And the reason why that number is so broad is because the government registries were absolutely destroyed, and there are people who have bodies that have yet to be recovered even today. In addition, more than 250,000 homes were destroyed throughout Port-au-Prince, which in the next slide we'll talk about led to more than 1 million displaced persons. So that was the true catastrophe. It was a very complicated sort of post-earthquake situation. A lot of people who were displaced moved into tent cities. And those tents varied from just like makeshift tarps over a set of sticks to more formal structures that might exist at some of the camps, like Sean Penn's camp. Sean Penn's in the upper corner of the screen here. He set up camp in an area called Pétionville, which is a more upper class region of the city of Port-au-Prince, and then had more formal tents as opposed to these makeshift tarpaulins in the bottom left. And with 1 million people being displaced, it meant that there were huge tent encampments throughout Port-au-Prince in various sorts of locations. And that led to a variety of different problems, including what we'll talk about in a little bit, which is the cholera epidemic. After the earthquake, there were a variety of different groups that swept in. Doctors Without Borders swept in. There was the International Red Cross. Pretty much every international aid organization that you can think of came into Haiti after the earthquake took place. One thing that I'll say about the generosity of the American people and the world in general is that the number of people who donated money and the amount of money that was donated after the earthquake was just absolutely mind-boggling. I don't know if we'd see that same sort of thing nowadays. It seems like the world's quite a bit more divided, but it was really encouraging to see the support for this group of people who were really heavily affected by this disaster. But Sean Penn, I think, was a little bit more of a sideshow, if you want me to be frank, than somebody who was actually making any sort of difference in the country. And there were a lot of groups that swept in the bottom left, or I'm sorry, in the bottom right of the screen, you can see a group of Scientologists who swept in as well. So there were so many different aid organizations that flooded the country that it led to a lack of coordination. And there's a whole entire separate lecture where we can talk about the UN cluster system and its various flaws that's focused on the number of aid organizations that came in and their lack of coordination. But the aftermath of the earthquake was largely disastrous and poorly coordinated. And that led to a lot of these controversies. So after the earthquake, three big controversies are highlighted here. The Red Cross was the main recipient of donor dollars. So I talked about how generous American donors were, donating like billions of dollars, literally billions of dollars, to different organizations that were working in Haiti after the earthquake. And the Red Cross was the #1 recipient from American donors. For those of you who are old enough at the time, you can remember that you could like text to a number and donate $10. And it was just so easy to donate money to the American Red Cross. But the truth is, the American Red Cross is absolutely fantastic at doing immediate disaster relief, but they're not good at the reconstruction aspects after disasters occur. So the Red Cross had too much money, and they can't say, we're going to give this money back to you. Or maybe they could say that. That would probably be better than what they did. But they squandered so much of the money that was donated, and it was highlighted through this ProPublica article that's listed here. In addition to that, Oxfam, which is the main British non-governmental organization, had a pretty big scandal in the country as several of their top administrative officers were implicated in a sex for money scandal with Haitian survivors of the earthquake. And then the Clinton Foundation and the main reconstruction planning group tried to establish a new resettlement camp for families to try to get people out of some of the tent cities. And they planned that camp in a very poor location in coordination with some of the aristocracy in Haiti. So it was scandalous in several degrees. One, in the fact that they built this new camp in a floodplain, and immediately during the rainy season, all of the houses were flooded. Two, there is a huge subsistence farming culture in Haiti, and this land was not arable in any way, shape, or form. And then three, the money that came from donors went directly to the aristocracy in Haiti as opposed to going towards the people that really needed it most. So here's me before the earthquake. You know, I am a non-traditional medical student and physician. I graduated with undergraduate degrees in photojournalism and English. What turned me on to medicine is spending a summer in Haiti during my junior year of college. I was doing a photo story on a physician's assistant who lived up there and worked in a remote area of Haiti. And while I was there, I had a number of different experiences that just kind of turned me away from the photography and documentary aspect of my work and turned me on to the direct medical care. And in this picture in the upper left is the first baby that I ever delivered. So it was a really crazy experience and was something that moved me in the direction of wanting to go into medicine. Down in the bottom center, you know, that's young me hiking throughout the mountains of Haiti. Haiti is actually a mountainous country. Haiti is the Taino word for Haiti, and it means mountainous land. And then the upper right is a picture of me with my parents during my white coat ceremony at Michigan State University's College of Osteopathic Medicine. Like I said, this upper left picture is me setting up these rainwater harvesting devices. So I worked with this organization called Raincatchers for about 8 years throughout the course of my high school and college years into when I was in graduate school and medical school. And then these are pictures from me during that initial summer that I was in Haiti working on that photo story, working with Teresa, who's a physician's assistant who lived up there in the mountains and ran this primary care clinic. And then our various sorts of guests. When I started medical school, I brought a number of people down with me, people from Michigan State University, and then a bunch of friends. This picture in the upper left is going to come up again in the end of this presentation, but I love to show this picture because all three of us are doing all sorts of crazy things now. Jordan, who's in the blue and white striped shirt, is a nurse anesthetist in Detroit. And then Lucas, who's on the far right, is a health design consultant who lives in Rwanda and then works with all sorts of different organizations like Save the Children, Doctors Without Borders, and all sorts of different other groups. This was me during the earthquake. So when the earthquake happened, I was actually sitting in Dr. Terry Taylor's tropical medicine class at Michigan State. So I I remember we were getting a lecture on Chagas disease. I don't know if any of you have gone through like really traumatic events, but for me, when I found out about the earthquake, it was a really traumatic event, and I remember that whole night very distinctly. I was sitting in class, and I got a text message that told me that there was an earthquake in Haiti, and I immediately was concerned for all of my friends. So I left class. I left class and immediately went home and tried to get in touch with my friends to make sure that they were all safe and that they were alive, because the earthquake was an absolute devastating event. So I was on the phone for hours and hours and hours. And my coping strategy for dealing with all that is Jets Pizza. I don't know if y'all have Jets Pizza where you are, but Jets was what got me through residency in Detroit. So I was mowing down on pizza and then staying on the phone all night. But all of my phone calls and all of my work led to me kind of taking a leave of absence between my second and third year of medical school, working on my master's in public health, and then heading to Haiti with a group called Humanity First. So I was recruited by the organization. Sorry, my dogs are going absolutely crazy. So I went to Haiti with Humanity First and worked as an administrator for a primary care clinic in an area called Seguin, which is, if you look on the upper right-hand side of the screen here, you can see the area where there's a dark green coloration. So kind of just over here. And it's by one of the two national forests in Haiti, Parc La Visite. And it's probably about, it's located about 5,000 to 7,000 feet in elevation. And I think if you look at this map, it makes you think that it's a very like green and beautiful area. But the real truth of it is like it's more of the like bottom right picture where you can see all of those different moto drivers coming up. Haiti in reality is 95% deforested. So there is very little greenery. And Seguin's one of the poorest areas in all of Haiti. It's isolated in many ways. It's very hard to reach. And there is just rampant malnutrition and all sorts of different problems. This is on the left side of the screen is the group that helped to run our clinic. So that's Dr. Clayton Bell in the middle of the picture in the red shirt. He's a family physician who was the primary doctor at the clinic. And then next to him is Margaret Veal, who is the nurse practitioner. They were the two primary caretakers or primary providers at the clinic. And like I said, I worked as the administrator. So my job was mainly to ensure that everything flowed appropriately. And then I did all of the public health related work. So I did all of the recording of the various sorts of illnesses that we were seeing. And then, as I'll talk about in this next slide, I worked with a group of 12 community health workers to manage various sorts of illnesses throughout the community. And this slide really highlights some of the successes and failures of my time in Haiti. I mean, I think it's really important for us to acknowledge the things that we do well and the things that we don't do well. No matter what we do, we're going to have successes and failures. And I think the Community Health Workers Program was a huge success. It helped to lay down the infrastructure and the foundation for the work that we did during the cholera epidemic in the country. And the main focus of the community health workers before that was looking at childhood malnutrition and addressing needs related to hypertension and chronic hypertension management throughout the countryside. And we really did a fantastic job of that by utilizing female providers throughout the area who lived in different districts outside of Seguin, and were able to provide just really high quality care. But there were some things that I did that were absolute failures, like that latrine in the upper right-hand side of this slide. This was built with one of the nonprofit organizations who also worked in Seguin. And we agreed that we wanted to try to build it with some sustainable materials. So we tried to lay the foundation for it using bamboo as opposed to using steel rebar. And that led to it collapsing roughly 6 months after it was built. So once the rainy season happened, the foundation was not secure and the entire thing collapsed. So it was a disaster, but learning experience and an example of, what can happen if you don't plan appropriately. At the bottom right is an elementary school that we built with Humanity First, and that was another success story. So something that we built while we were there in 2011 that still exists today. So it's a way for kids to get education throughout the community, and it's something that I'm really proud of. But the cholera outbreak took place in Haiti in mid 2010 into the fall of 2011, or I'm sorry, into the fall of 2010. And it started in Port-au-Prince, or actually it started north of Port-au-Prince by the Artibonite River. Unfortunately, one of the Nepalese peacekeepers brought it to the country, and due to some faulty sanitation, it ended up flowing into the Artibonite River, which is one of the main rivers throughout central Haiti. And from there, it spread throughout the country and led to just a disproportionate or ridiculous number of deaths. And Doctors Without Borders came to the country, I think initially because of how isolated we were. And again, I thought that we would not be affected by the cholera outbreak. I think that was my optimism, but my realism was always there. I knew that it was going to come to us eventually. I knew that a lot of the people who lived in the community would go to Port-au-Prince and sell the vegetables and fruit that they grew. So at some point, the illness was going to come to our community, and then it did. And initially, we were able to contain it, but once it became more widespread, it became more challenging for us to try to take care of it without the assistance of a bigger donor. So Doctors Without Borders came and helped us to establish a cholera treatment unit. And they basically like built the house and gave us the keys to run everything. So we ran the CTU for 3 months through the first wave of the cholera epidemic and cared for all of the patients that came in through our community. And it was just a huge blessing in so many ways, but was also very stressful in a lot of ways too. Cholera is a very treatable condition, but it's also something that requires around-the-clock attention. So it led to a big stress on us while we were trying to run our clinic at the same time. And like I mentioned, the community health workers were a big help to helping to do outreach and encourage people who had cholera to come to the CTU as soon as they could for treatment, and to minimize the spread of the bacteria throughout that community. It was cool. I had an absolutely lovely time. During the time that I was in Haiti, I got the chance to fundraise through various sorts of efforts. This picture in the upper right is a chance that I got with Clayton and one of our friends, Jeff, who's a vascular surgeon now in Portland, Oregon, to ride our bikes across the country to fundraise for our efforts in Haiti, both at the clinic and with the community health workers and the cholera treatment unit. And I think it's funny, the Clinton Foundation gave us a big donation while we were riding across the country. But at the time that Bill Clinton actually called, I was using the bathroom. So I wasn't able to take his call, which is something that I think is a little bit hilarious. I've met Bill Clinton twice in my life, and I had the opportunity to kind of take his congratulatory phone call. But I couldn't do it because I was not available. And then I came back to the States. So I wrapped up my time in Haiti, came back to the States, and here's a picture of me with some of my co-residents at Henry Ford Macomb, with our pink scrubs that we stole from Baltimore shock trauma. And I finished up my residency and came to Brown University, where I did my global emergency medicine fellowship. But en route to doing that, I created a nonprofit organization with some of my crazy runner friends called Run Haiti, where we brought people to Haiti to do all sorts of crazy races. You know, nowadays, Haiti is so much more chaotic than it was back in 2014 through 2017 or 2020 even, where there was an opportunity for us to bring people to Haiti and really explore the country and the beauty of the country. So we did several different ultra marathon races throughout the country, and then we had a half marathon that we brought people for every year. And it was really fantastic to do that. All of the proceeds from these races went to the community health workers program, and to an associated clinic that we worked with in Quatabuque, which is just outside of Port-au-Prince. So this was a really fantastic experience and a really good way for us to give back. I'm a huge runner, a huge cyclist, so this was a really cool way for me to translate some of my passion into a way of giving back to the people that I love in Haiti. And then these are some shenanigans that I got into through residency and fellowship. On the far left is a picture of me after when I was a PGY2. I biked across the entire state of Michigan, like 250 miles in a single day to raise money for Team Fox, which is a Parkinson's organization. And then those other two pictures are pictures of me setting some world records, pushing my kids in a stroller during a marathon and a half marathon during fellowship. From there, during fellowship, I moved to Rwanda, and I've been working there ever since. It was fortuitous for me to translate to Rwanda, which is a really stable country, very easy to work in, with a group of people who are really supportive. And this is a picture of some of the EM residents during the time that I was in fellowship. Many of these residents have moved on to becoming faculty members in Rwanda and other locations at this point in time. And I've continued to work in Rwanda ever since for various sorts of projects. So I think when I talked to Justin about this particular presentation, one of the things that he mentioned is that people might be interested in working abroad on different sorts of global health projects. And I think one of the intersections between global health and wilderness medicine is really like first aid training and wilderness medicine, in the sense of like providing care in an austere environment. And for me, I've done a lot of those sorts of different trainings in Rwanda. And I think that those are the sorts of avenues that people who are interested in wilderness medicine and are well trained in emergency medicine can participate in. And the good thing for us as emergency medicine providers is that we can engage with some of our colleagues who might be nurse practitioners, physician's assistants, EMTs, or paramedics to come with us. Because a lot of these skills can really help to improve outcomes for people in low and middle income countries, and don't require advanced degrees. For example, the Stop the Bleed trainings, this is something that we did throughout Rwanda. We partnered with a local community organization called Health People Rwanda, that involves people who aren't physicians. So like teachers, engineers, people who are computer scientists in Rwanda. And we train them on how to do basic hemorrhage control. And we did training the trainers sessions throughout the country. We ended up training more than 120 individuals, who then went on to train more individuals. And we're aiming to expand the training sessions even farther. In Rwanda, they have something called Car Free Day. So twice a month on Sunday mornings, they shut down all the main roads in the city to traffic and open them up to pedestrians and cyclists and rollerbladers and stuff like that. But as part of that, they also have health teaching. So we're hoping to work with Healthy People in Rwanda and the Rwandan Ministry of Health to offer these sorts of Stop the Bleed trainings during those sessions to reach an even bigger audience. But this is something that's very practical that can be done in any sort of lower middle income environment. Stop the Bleed is very easy to teach. The lessons do not take a lot of time to prepare. In fact, there's a slide deck that the ACS and Stop the Bleed have available for you to use. And the main sort of cost that's associated with it is is related to the tourniquet purchases. So the training tourniquets and then the tourniquets that you provide to people that take the course. We were fortunate also to expand some of our training efforts to the Rwandan National Police. So one of the graduates of the EM training program, in Rwanda, Emile Musoni, is a police officer, and we were able to get a grant from the U.S. Embassy to train the Rwandan National Police Force in BLS, as well as first aid training and stop the bleed. And that's been amazing. I mean, this has been one of our more successful endeavors throughout the country. Emile has been absolutely fantastic, and the Rwandan National Police have really embraced this program. We've trained more than 1,500 providers, more than 1,500 police officers at this point in time in BLS and Stop the Bleed, and that can make a huge difference. In Rwanda, I think people might be skeptical of us doing BLS training because, you know, what is the end game? But I would say that, you know, with defibrillator access and shockable rhythms, you can get positive outcomes for a certain portion of the population. And I think that we really should be thinking about how we can make a difference, even in austere sort of environments. So we should be thinking about how can we get defibrillators to this environment? How can we get training to this environment, as opposed to we shouldn't be teaching this sort of thing. But I'm really proud of these police trainings, and I'm really excited about the direction that they're going in the future. The other thing that we've been doing is these Rwanda District Hospital trauma trainings. And this is a program that's been going on for the last 3 years, where we have been doing a series of 3 different teaching sessions at district hospitals throughout Rwanda. So Rwanda has 42 district hospitals. We have this program operating at this point at 10 different district hospitals throughout the country in various geographic regions. And the sessions involve an initial ATLS-like training. So it's like ATLS, but it's not ATLS. The reason being, like, ATLS is trademarked by the ACS, and ATLS is a big process in terms of having it come into the country. So it's similar to ATLS, but a little bit more focused on blunt trauma. There just really isn't much penetrating trauma in Rwanda. Most of the trauma that you see in the emergency department is due to blunt force trauma and motor vehicle accidents. So the initial session is a general sort of adult introduction, followed by a pediatrics session, which is more focused on a little bit of PALS and a little bit of pediatric trauma. And then the last section is more of an overview of everything, and then a review of some of the special populations like geriatrics and pregnant patients. And like I said, we've been operating that for about the last 3 years, and are always on the move to try to expand the program to improve care throughout the country. And you can see pictures in the bottom left here. You can see this is us in Kabuye, which is in the western portion of Rwanda off Lake Kivu. And that's Pascal. He's one of the EM faculty at University Teaching Hospital Kigali for the residency program. And then on the bottom right, you can see, I told you that this was going to come back up, a picture of me with my friend Lucas. And on the bottom right, you can see me with Lucas again. And this initial picture was all the way back from 2009. So about 15 years ago, 15 years of difference between that first picture and that second picture. We both managed to reconnect with each other in Rwanda, which has been really fantastic. And we've managed to stay friends with each other through all that time. So he's working as a healthcare design consultant with various nonprofit organizations based in Rwanda. And it's really fantastic to be able to see him every time that I travel there. So on that note, I'll transition to some resources. If you're interested in reading more about the earthquake and its aftermath with some critical perspective, I think that these are some good books. The Big Truck That Went By is by Jonathan Katz. He was an AP reporter who was based in Haiti at the time that the earthquake took place. And he offers a lot of perspective on some of the controversies after the earthquake took place. And then Haiti After the Earthquake is by Paul Farmer, primarily, but has all sorts of different pieces of literature like poems and short stories from people who lived in Haiti during the time that the earthquake occurred and the aftermath, and is a really good overall book that will help to give some perspective about what life was like there after the earthquake took place. In Rwanda, I think this is a really good book that I would really recommend to anybody who wants to work in Rwanda. If you are not aware, there was a genocide that took place in Rwanda in the 1990s from 1994 to 1995. And a lot of Rwandan culture now is based off of reconciliation after that. And this book will give a lot of perspective about what happened during the genocide. And I think it's foundational to helping to understand the direction the country's gone into since that point in time. So it's a good reference. And here's some great pictures of Lizzie Barrett, who is a PGY3 at Henry Ford Macomb. She's just a very passionate teacher. And I have had the pleasure of working with her in Rwanda, teaching the district hospital trauma courses. And I think that, you know, she's going to go on to do some absolutely great things, and I'm excited to work with her. We had a phone call today with some emergency medicine physicians in Malawi, and I think it's a good avenue for us to move in the future. But to kind of summarize the lecture, I think when it comes to global health, it's all about making connections, and it's all about figuring out how you can take the skills that you have and translate them into the needs that exist throughout the communities where you want to work. And I think from a wilderness medicine perspective and an emergency medicine perspective, we're really good at improvising. But we also know how to teach everything from really complex sort of procedures to really simple sort of things. And I found that teaching things like stop the bleed, BLS, and ATLS have been really easy for me to do and have been really well received and welcomed throughout the country. So I would encourage you to take some of the skills that you have and think about different ways that you can reach out to the different groups and different locations in low and middle income countries, and try to use your skills to help improve care throughout the country. You can do it. It's really not that hard. But it's just really important that you establish partnerships that are collaborative and you're helping to meet the needs of the places where you want to work. And I think we'll talk about that a little bit as we go into the Journal Club article. I think I try my best to try to work with my colleagues in Rwanda. I mean, most of the work that I do, if not all the work that I do, is in direct collaboration with attending physicians in emergency medicine in Rwanda. So the first step is really establishing those connections and then kind of going from there to find projects that you can help with that will directly benefit the population. Anyways, I am rambling a little bit, so I am going to stop sharing and I'm going to hand it over to Lizzie Bear.
Thank you for that marvelous introduction with those pictures, Kyle. Like Kyle said, my name's Lizzie. I'm a almost PGY3 at this point. Let me just share my screen for you guys. My interest in global health started when I was a kid. I grew up in a family where travel was a kind of cornerstone to my development, and now trying to figure out how I can apply that going forward with my career, not only in medicine, but specifically in emergency medicine. So having Kyle as a mentor has been absolutely instrumental to my current projection with what I've done as a resident and kind of translating that to going forward with potential fellowship. So all right, so the article that was sent out as a Journal Club article was entitled A Toolkit for the Decolonization of Global Emergency Medicine, and I'm going to kind of summarize that and then talk a little bit more about my experiences thus far. Okay, brief introduction. So the goal, I think, was summarized very well in the first couple sentences of the article, being that the goal of global emergency medicine and GEMA as an arm of SAEM is to create relationships between high income, high resource countries and the low middle income countries. And these relationships are really designed to foster and promote high quality emergency medicine care, education, kind of across the global stage. The article focuses on barriers that we're currently experiencing when this article was written back after the GEM meeting in 2022, and kind of identifying 5 key areas that we think over the short-term course and the long-term course we can work to reduce the barriers. Big ones being underrepresentation of these experts and providers from the countries that we are working with. This is kind of a broad idea, underrepresentation in terms of their voices on a global stage, whether that be at conferences, with research, publication, and sadly, even in projects within their own country, making sure that we have local partners and champions that are really driving the show. And kind of like Kyle touched on, they're making their voices heard and what they need in their setting known, so that we can not necessarily come in and design these grand plans that fit well with a higher resource location, but we're targeting and supporting the needs that they have at the time in their populations. Another barrier in terms of language and perception for global health is this white savior complex that just grinds my gears to hear and even read. That we are, like I said, going into these countries and fixing all of their problems and then leaving, and everything's great. It's not realistic, it's not sustainable, and it's a term and an ideology that's kind of plagued or global medicine, as both internally within the community and externally as the perception to the public. Next is sustainability. This is something that I've kind of focused on a lot in all of my experiences, is not doing a one and done trip, not going in and providing a clinic for one day, but creating these relationships that provide sustainable, supportive partnerships to meet the needs of the location and community at the time and going forward. So the article was based on discussions that were held at the SAEM annual meeting in 2022, and they identified these 5 areas of themes that they think that we can kind of work to improve and ultimately decolonize as GEMA is working towards global medicine. So these include access, awareness, language, representation, and recognition. And I'm going to kind of break these down in terms of what we define these themes as and what we're going to do in the short term and long term to work to improve them. First, access. So the definition, and this kind of focuses on education, not necessarily humanitarian efforts or clinical work, but the access to education. So who is providing the education, who is teaching, and who is on the receiving end of that education. Barriers to this include funding. That's kind of a running theme throughout this. These projects, while simple and easy to kind of make happen, they do have a cost to them. So whether that's grants, donations, nonprofits, organizations that are providing that funding to allow these projects to take place. Another barrier being telecommunication, both in the sense of like a phone call, a Zoom call, or access to the internets. Do they have computers to access things that we use every day, like UpToDate, WikiEM? Do they have access to publications, PubMed? Are they able to receive the New England Journal of Medicine? And also a big kind of theme throughout this article is the recognition of these providers and their expertise. In the short term, working to explore funding opportunities, whether that's what you have available through your fellowship program, your health system, local government, the government as a whole, what grant opportunities can you apply for, and that would help you kind of make your projects come to fruition. And prioritizing investments in these telecommunication strategies. So whether that's internet infrastructure, computer technology, just making sure that not only are we providing the education, but we're providing avenues for who we're teaching to continue to further their own education with the most recent and high impact journals and resources that we use every day here at home. Long term, lobbying for the increase in educators from underrepresented communities, whether that's opportunities for them to come and speak, providing grand rounds at national conventions, working with partnerships in your university, fellowship, residency, etc. And then the last one I think is important is creating feedback mechanism that goes both ways. So we're able to hear the concerns and the thoughts about what we've done in these locations, and we're also able to provide feedback on our end to what we think was done right. So like Kyle said, it's really important to recognize what you're doing well and what you're doing not so well, and to improve ultimately in the future. Next, awareness, kind of hand in hand with cultural humility. So how do we recognize that global health might have not come from the best of circumstances back in the day with the colonization? And how can we recognize that, understand the origins, and work to move past them and to improve outcomes and relationships internationally? Barriers to this is the unilateral decision making, kind of like I said before, with the idea that the high income country is going to this location and saying, okay, this is what we're going to do, and not necessarily allowing for that feedback, that communication to be a two-way street with our partners abroad. The portrayal of global health in the media, pop culture, and kind of how it's been negatively denoted in the past. There have been several articles about mission trips and how unsustainable and harmful they can be. So working to improve our image and really live up to the goals that we're setting forward in this article. And then also the cultural humility, the expectation and the pressure that these providers in the communities, whether that's nursing, residents, physician attendings, they have this pressure to adopt what we do at home into their setting, which might not be a perfect fit. It might not be realistic based on the resources that they have in their setting. So even when I was a medical student and I went to Malawi for about 2 months, I was a new fourth year, halfway through my fourth year, and these attendings and these residents were asking me questions and like taking what I was saying as like the Bible. And I'm like, whoa, guys, you are far more experienced than me. I appreciate that you are asking these questions, and I'm going to do my best to answer. But they just felt like what I was saying was, the word of God. And that's just very important to set the expectation that they know more about caring for the people in their specific community environments than we ever will. So it's something to be highlighted. And this can be all kind of the barrier, or the goal of lowering this type of barrier is education. So before you go abroad, understanding what their cultural sense is, understanding what they need, understanding to the people that are traveling, that it needs to be a two-way street. We need to communicate and understand that they are the ones kind of driving the show, and we're there to support them. Long-term, kind of similarly to what I've said before, education, a network of mentors to provide this pre-departure education. So if you're going to a place you've never been before and you're not with people that have been there, is there some sort of network that we can create to have somebody that's there as a local contact to provide the education and the cultural sensitivity training that you might need? Next is language. There's two parts to this. So one is, how do we talk about global health as a whole, kind of the terms that we use, mission trip, white savior, third world country, these outdated, very harmful, politically incorrect terms that are still circulated today. So how do we work to improve how we're speaking about what we're doing as a whole? And also language, how do we communicate with people? If there's a language barrier, what are we doing to overcome that barrier? Are there translator services set in place? Are we going with a local champion who's bilingual, which is very helpful? When I went to Peru, luckily I do speak Spanish, but we actually had a group of, I think there were college kids who were studying English, but they were also obviously fluent in Spanish. So it was educational for them because they got more experience, and it was an absolute important resource for us to have when communicating with patients. So understanding what opportunities are out there, what resources you have, and just making everybody aware of them. Even back home in our departments, are we using virtual translator services? Are they available? What can we do to increase their availability? And then in the long term, supporting language learning within medical education. Before at Michigan State, it's where I went as well. We had to take a medical Spanish class before we were allowed to go on any of these trips abroad. So I think that that was instrumental to a lot of people having a basic knowledge of how to communicate, in a very conversational, not technical way. But it was something that I think should be more broad spread if you're ever planning on going somewhere. Next is representation. Kind of the running theme, like I said, is how are we representing these low middle income country communities, and who is setting the agenda and the priorities for these projects. Barriers to this: COVID was a huge setback for all of global health. Obviously, there was massive travel bans internationally. I think there's actually a positive with COVID is like we're doing today, Zoom, and the more increased utilization of different methods of communications and meetings, and providing education to other countries that we might not be able to physically be at, but we can provide this virtual learning situation. Time zones is just another classic one. Like Kyle and I were saying earlier today, we had a meeting that it was the afternoon for them, but it was very early morning for us. So just being flexible and being open and understanding that there are some factors that nobody can control, and it's just working around them to continue to encourage these partnerships and projects going forward. And then long term for this is lobbying for global health to be emphasized in medical education. I was very fortunate at where I went to medical school. It was very well known. Michigan State had a very expansive global health curriculum with multiple trips offered depending on which year you were on, and supportive of even research and other avenues that you can use to be involved in global health. So making that the standard as opposed to the norm, that it's not very offered very often. For example, Henry Ford, I love my residency, I love my health system, but they don't support global health rotations or anything. So working to help understand why that's the norm and what we can do to expand opportunities for people that are interested. And the last of the 5 themes being recognition. Again, this kind of goes back to what's been said before, but how do we elevate and recognize our partners abroad? What can we do to provide them with grants to come to the US, come to these international meetings, make them give them a seat at the table to kind of express their concerns, and what can we do to support them in that, whether that's grants, nominating them for awards so that they can participate in these conferences, and working to encourage continuity. So obviously with medical education in the US, there's a lot of turnover. You go through your residency, it's 3 or 4 years. You go through fellowship, it's 2 years. And then what's next? If you're going to continue that relationship or that partnership, that's phenomenal. And I think that should be the goal. But if you can't, for extenuating circumstances, working on a backup, who's going to take over from here, and not just kind of leaving people high and dry. And then avoiding the one and done projects. The sustainability is something, like I said before, it's very important, not just going in for a week or a day and picking up everything and never returning, making sure that these are long-term sorts of partnerships. In summary, the goal of this article was to kind of initiate the plan to decolonize global medicine, specifically in the avenue of what our field is emergency medicine, and kind of pinpoint very practical solutions and areas that we think that we can reform within a relatively short period of time. That's being increasing communication, increasing funding, and increasing education in all sorts of different avenues, and then fostering those long-term partnerships. Like Kyle said, it's very easy to do a stop the bleed training. It's very easy to teach ATLS principles, but if you don't have the boots on the ground or the partner and the champions in the countries, you're not able to do that. And you don't want to just go in and kind of take over. You want to have somebody there and understand what they need and make sure you're meeting those needs. And then encouraging flexibility. I think one thing about EM physicians is we're great at all sorts of things. We're used to being awake at random hours of the day, and we have very flexible schedules. So I think that that's kind of a very easy thing to address, but just making sure it's well known that we might need to be the more flexible ones occasionally when working with partners abroad. And then the article summary is just at the bottom, which Justin sent out to you all. So kind of transitioning a little bit from the article and a little bit into my experiences. Like I said before, global health has been something that's very important to me, and I'm very pleased to see that I can see that going forward into my career as opposed to just kind of a hobby. My introduction was back in college in 2016. I think I was a sophomore at the time, and I went to Mexico. I was a Spanish minor, so the Spanish language was something, and still is something that's very important to me. And I was able to go on this trip with ISL, which is International Service Learning. They do a variety of trips, whether that's research or education. This was a little bit more focused on clinical experience. We ran a clinic. They go to the same villages every 3 months, and they do like a week-long clinic. So we're seeing patients, providing education on diabetic management, hypertension, and then urgent care services, looking at kids' ears, sore throats, runny noses, and then being able to provide medication and also connect them with local physicians for longer term care. We also did a little bit of surveying work in the top left here. We went to different houses in the villages and, did they have clean water, electricity, and then connecting those families with organizations to work on providing the resources if they were lacking. Oops, there we go. And then I wouldn't be where I am today without Michigan State. They are very supportive of global work, and I was able to do multiple trips while a medical student. In my second year, I went to Mexico again. This was a more educational experience. In the top left here, we went to one of the hospitals in Merida and learned kind of what their surgical system was like, and learned not only their medical practice, but how medical education is done in Mexico, and worked with their partners and did a couple of outreach programs within the communities outside of the city of Merida. And then in Peru, we were there for 3 weeks. We took a very large team, about 75 people in the middle here, nurses, OBGYNs, infectious disease specialists from Lima, and we worked with the translators from the high school students from Spain, which was a phenomenal experience. We did a week-long clinic. They do this every year in Iquitos, Peru, which is right off the Amazon, providing all sorts of resources and physicians. Infectious disease was very interesting to see at like a clinic setting like this, as OBGYN was too. They provided screening for STIs, for cervical cancer, a whole host of resources. And in the middle here, this gentleman is Dr. Travis Gordon. He is instrumental to the advocacy for DO physicians around the world, specifically in Latin America and Mexico. Very strong mentor of mine. And I think that the advocacy for DOs internationally is something that's an ongoing effort that I would love to be a part of. But it was a very interesting experience. And then we took a boat, the Amazon Queen, through the Amazon for a week, going to remote villages and providing care and vitamins and toothbrushes and just, daily needs. It's where I learned how to do a pelvic exam, was on that boat, actually. So very interesting kind of setting to learn OBGYN care. The next one, Blantyre, Malawi, was in my 4th year of med school. I lived there for about 2 months and worked at the hospital. This was my first big clinical experience in global health. This is the emergency department here. This was their trauma bay. So seeing how the resources, how creative they're able to be with the limited resources they have. And then the picture on the far right is the Pyxis in the ER, and looking at the medications and seeing what they actually have available to them and how they're able to make it work. I was half time in the ER there and then half in the internal medicine floors. It's a huge humanitarian effort there. I was there in 2022 when COVID, it was kind of at the tail end for us, but it was still rampant in Malawi. So I was able to see Doctors Without Borders and their efforts there, along with Johns Hopkins University and the CDC. So it was a very interesting experience. Kyle and I are both very much in love with Malawi and hoping to go back to work with their EM trainees there as well. And then my most recent experience with Kyle in Rwanda, the trauma training, teaching, like Kyle said, kind of ATLS-esque protocols that made sense for the country and the resources that they had at the district hospitals. We taught a lot of PALS training, CPR on children, choking infant, how to manage basic blunt trauma, when to transfer. We had a butterfly that was there so we could teach fast exams, and then the complications. And kind of for the district hospitals, the big focus was when to transfer, as it is an ATLS, stabilized transfer. That's our whole kind of philosophy in emergency medicine, community settings, both in the US and abroad. I think each day we taught to 5 district hospitals. We maybe taught about 300-ish nurses, students, physicians, residents, and they were able to take a pre-test and a post-test to kind of assess knowledge. And also, not only the knowledge was important for data collection, but also their level of comfort. Did the training actually have an impact on how comfortable they are with these patients? Or was that something they needed further experience with in order to be comfortable? It was a phenomenal experience working with the physicians there. On the top here, Joseph is one of the ER physicians, and he was a great colleague to work with, absolute hilarious individual. And then Pascal too, somewhere in here, Kyle pointed out too. So great experience overall. Love to continue research and work in Rwanda and Eastern Africa going forward. But I've also rambled and used up all of your time. So if anybody has any questions for Kyle or myself, happy to answer. Justin's got our contact information too. If you would like to participate in anything, we'd love to have you.
I'm sure all of our participants feeling equally as underachieving as myself here. So if anybody has any questions for them, which I'm sure you will, please go ahead and ask them. I can ask some.
Go for it, Justin.
So what's your current work? What are you looking forward to upcoming? What are your future plans?
Yeah, I think for me, continuing with the Rwandan National Police trainings, that's been a big thing for us. I mean, the Rwandan National Police also include some of the UN delegations that they have to various locations. So they send peacekeeping troops to Central Africa and to all sorts of different locations. And the total roster for the Rwandan National Police is like 20,000 people. So my hope is that we can try to make sure that all the Rwandan National Police are trained in BLS and stop the bleed. And that's ambitious, but I think we can do it. It really seems feasible. And really, when you think about the bigger picture of cost effectiveness, is really not that expensive. In terms of other next steps, I think, continuing to support the residency program in Rwanda is something that I want to do. I really have had a collaborative relationship with our faculty in Rwanda. They're my best friends, and I want to work with them and make sure that they get the type of experiences that they need, and that we can collectively make sure that their residents are really trained to do the things that they need to do. And then moving on to, Lizzie mentioned this, like going to Malawi is something that I think we're both interested in. How can we take some of the experiences that we've had in Rwanda and translate them to different locations? Malawi is somewhere that both of us have worked and that we'd love to get back to. So I think if we can make that happen, that would be huge.
It looks like we do have a question in the chat here. I can read it out loud for anybody who's not in the chat, but it says, do you feel that your MPH actually helped you in these pursuits? Would you do it again, or recommend people with similar interests or goals pursue an MPH?
I think it depends on, I think with any advanced degree, it all depends on what you do with it. So you can get a master's in whatever, or you can get a doctorate in whatever, but it's useless unless you are doing it in something that is practical. And that's a strong opinion for me, but it needs to be applied. For me, I did my master's in public health while I was living in Haiti. And I was working with the community health workers. I was working during a cholera epidemic, and it was really practical for me in terms of the experiences that I got. And I was able to translate those into things that I do now. If you're going to do an MPH just for getting the letters, then don't do it. But if you can get an MPH that's going to translate into some of the work that you want to do, then you should do it. I mean, if you want to do an MPH and you have a strong desire to teach stop the bleed, or you want to teach BLS, or if you want to teach something otherwise, do it. And make sure that your MPH is something that you're learning practical skills and it's translating into something, into what you're passionate about. But I think just doing degrees for the point of doing degrees just isn't, it's a waste of money, and it just doesn't seem really practical. And I don't think it really gets you anywhere. So, if you're passionate, go for it, but make it something that's useful to you.
I know that there's often asked questions in the WMS membership about how to be involved and what is global health. You'd think they'd be more connected of subspecialties of emergency medicine, but for anybody who's interested, the WMS is in the very early stages of planning a rotational elective at the Wangshu Sherpa Hospital in Nepal. So that should be coming up somewhat in the near future. And then our fellowship before COVID, before my time, would go down to Peru and teach wilderness first aid to people locally. And then those people who took the class would then teach it to other locals. And then it's somewhat becomes self-sustainable. But I don't think it's been resumed, at least within the fellowship core, since COVID. So I agree with what Lizzie said. COVID did kind of put a kibosh on a lot of what I've seen outreach-wise. What?
Yeah, but I don't think that means
No,
can't make it happen in the future,
I think it should probably be coming back. I think I know we have somebody who's interested still. Regarding future possible like disasters at the scale of something like what happened in Haiti, do you think that the joint efforts of Doctors Without Borders and the Red Cross and all of the aid that came to Haiti have come up with a more collaborative plan, or do you think there's a potential for this to somewhat happen again?
Probably not. I mean, I I just think I frankly, like, the international NGO sector is very disjointed and non-collaborative. If you look at Israel, Gaza, you can see the disastrous efforts at trying to coordinate humanitarian aid. And it's, I'd love to have faith in the United Nations to try to mitigate some of the disasters that exist. But unfortunately, again, to bring up Israel, Gaza, it just is a lot of opinion without much enforcement. And I think that leads to, some downstream negative outcomes for some of the most vulnerable populations. So I think, the biggest disaster of our time right now is Israel, Gaza. Sudan's a pretty big disaster right now too. And every year throughout Southern Africa, we see, and India, in India and Pakistan, we see heat-related disasters beyond what you would see even in Arizona. And then in Mozambique and Malawi, we see a lot of cyclone-related disasters related to climate change. And there's just is a lack of concerted response effort. The international NGO system just is not the best way of responding to these disasters. And Haiti showed that, but unfortunately, we're slow to respond. And I think, like you mentioned, Justin, and you mentioned, Lizzie, like, unfortunately, COVID has kind of severed a lot of the bonds that we had internationally and put us back a little bit. But we need a new generation of people, I think, to come up and argue for a new system and advocate for a new system that can provide a better option than these international NGOs. And I think, maybe we should put that pressure on Gen Z and beyond to come up with some new innovative solutions.
We've been teaching essentially stop bleed, but hemorrhage control within our wilderness medical courses for quite a while. As you were mentioning, the Israel-Gaza conflict, we recently kind of added the new tourniquet relocation and conversion aspects of tourniquet application based on an article from the TCCC due to what's happened in Ukraine. So it's really interesting to see the ebbs and flows. Like, I don't know, during residency, I suppose when I started seeing tourniquets becoming more commonly used, at least locally where I was. And now we're starting to see concern with somewhat what they were seeing in World War II, where they're being left on too long and it may be used inappropriately. So it's very interesting to see what we're seeing, and hopefully we can teach the new relocation and conversion, and in addition to stop the bleed too. Although that's a bit, next level.
Yeah, I mean, I think we need to really try to prioritize simplicity when it comes to teaching. I think we as emergency physicians oftentimes get lost in the complexity of the knowledge that we hold. And in reality, the management of these basic sort of injuries is really simple. Like the management of hemorrhage control is direct pressure. And if you can do direct pressure for the vast majority of injuries, you can control the bleeding. Tourniquets should only be applied for certain portions of the injuries that occur. And if we can teach that sort of knowledge, we can really save some lives. I think the same sort of thing applies to BLS and ATLS. Like really focus on simplicity, focus on, the A, B, C, D, E of ATLS, and focus on how we can teach in a way that's really easy to digest, that people can follow. So if we can do that, then I think we can make a huge difference. But I think oftentimes we get lost in the minutia. I was listening to some podcasts about COVID today, and I remember just these debates that we would have that seem like just absolute garbage now about whether masks are good or bad, like whether touching your mask, like wearing a mask means you touch your face too many times and you can spread the virus. But in reality, like wearing a mask isn't bad. It's just like when we get so ingrained in the minutia, that's when we start to get away from the basics. And I think the same sort of thing applies to things like stop the bleed. And the same sort of thing applies to BLS, and the same sort of thing applies to like ATLS. So we just have to really focus on the fundamentals and the core of what we're doing, and like know that that's going to benefit patients without really getting too caught up in the little stuff.
What's the infrastructure of Rwanda? Is it like, are there really long transport times to the local hospitals, or is it like a pretty well established? I mean, they have emergency medicine residency programs. So I'm just curious about the actual infrastructure. I don't know much about the country itself.
I think for the most part, it's really well organized. They are one of the countries that's blessed with a large ambulance fleet, and they have pretty nice ambulances. In reality, the vast majority of trauma cases happen around Kigali, which is the main urban center. There are a few other urban centers. There's Ruhengeri, and then there's Butare. But for the most part, most of the traumas that happen are focused in Kigali, and they're due to like moto accidents and car accidents. And the response time is really quick. There are the few occasional cases that are outside of the city and more remote areas. And the transport time can be a little bit more prolonged in those sorts of cases. But for the most part, that just doesn't happen. Rwanda is nice to work in the sense that they do have a very well organized structure. So it's pyramidal in the sense that like at the bottom you have your community health workers moving to community health centers, then your district hospitals, then your tertiary care centers. And they all offer different services based off of what the acuity of care is. And it's amazing in the sense that it just is very well organized. Certainly there are some gaps in terms of technology, but the organizational structure is really strong, and the sorts of transport that is available for emergencies is there, with the exception of a few cases. I think when we teach Stop the Bleed, there's always the question of like, what do I do if I'm in X region of the country and my ambulance needs to travel 4 hours? And then we just kind of refer to some of the guidance from like ILCOR and things like that, which refers to, tourniquet management and the amount of time that tourniquet should be on for them.
Any questions for either of them from our audience? I think it was kind of overwhelming to them about everything you've done since, well, both of you since you were pretty young, actually. Would either of you be opposed to me sharing your contact info so anybody can reach out to you if they want to get involved or to ask any questions later?
Not at all.
Okay.
Yeah, feel free to share Lizzie's contact info.
All right. Well, thank you both very much, and thanks for everybody who joined. We've been, oh shoot, my dog's joining us.
I think my dog sabotaged my presentation as well.
I'm gonna end the session at this time. Thank you both for joining, and thanks for everybody who's participated. This should be up on YouTube within a couple weeks, I believe, and then I'll share it in the next month's email. So thanks, everybody.
Thanks, Justin, for having us.
Yeah, thank you.